Good evening, everyone. Thank you so much for joining us for part 2 of the amazing webinar series, I Crossed the Line. Today we'll be going through Edentulous and partially Edentulous case studies with Leif. Leif, how are you going? Thanks so much for joining us again.
Good to see you, Joe.
Yeah, so why don't you let us know a little bit about what we're going to be going through today?
Okay, well, it's a few things. We're going to be looking at, we're going to run through, obviously we're talking about edentulous spaces, whether that be full or partial. We've been very, very privileged and fortunate we can get 2 patients in today. So that's always a risk when you're filming and you've got live stuff happening. But that's okay. We're going to walk through and we're going to talk about basically looking at small spaces to scan, which are actually, I mean, most people think, oh, there's one tooth missing, it's quite easy, but it's actually not. And I'll show you some of the tricks to get those undercuts. That's part 1. We're then going to look at some full edentulous arches, especially uppers tonight. We're going to talk about the 2 ways that you can record them. So you're going to make a new denture, a new full upper, or even an implant restored, but you still need to take a full arch scan. So we're going to do that tonight as well.
Perfect. Look, we tend to see a lot of people not having a lot of trouble with taking scans for, you know, fully dentate patients and everything like that. But when it comes to the partially or fully edentulous patients, we see that a lot of the users kind of tend to go back towards impressions. Why do you think that is?
So you mean they didn't cross the line?
No, they don't cross the line. That's right. Why don't you think they do that?
It's because, I mean, and I guess, look, I'm a denture practitioner, so I don't have a choice, right? I can go back, or I can do the new way, right? You might be doing crown preps and implant, single tooth implant scans with your scanner, but because there's so much things moving, this is the main reason. There's a lot of mucosa that's moving, and it's just learning to really control that. And as I said, managing those undercuts. But what actually the hardest part is, and the reason people go back across the line to pick up that impression tray, is because between the tooth, another tooth, and the stuff in between that moves a lot, it's very hard to get from here to that other solid surface. And so that's what I'll try and help everyone through with this evening.
Excellent. All right, well, we're going to cut away to our practical part. So just give us a little bit of time to set up and we'll be right back with you. Thank you.
Well, okay, let's jump straight now into our practical component of our seminar today, our webinar. We're going to look at a few things today, and the first thing we're going to look at is hand techniques. So if you were with us last week, you would have heard me talk about posture, computer position, scanner position, patient position in relation to you. I am a big advocate of frontward facing scanning, just because you have a really good specifically for denture indications. Let me clarify that. Because you can really see the anatomy head on, whereas if you're behind the patient, sometimes it's quite tricky to see the anatomy and what you're doing. So in a denture scan, sometimes you are absolutely intimately looking at that screen, but you are looking at that patient as well. We have a mannequin model of a real live patient on a chair mount today, which is actually a really great way to learn. And so we're going to have a quick look at a single tooth missing. Now you might think, oh, come on, Leif, look, I'm looking at this for the advanced stuff. Well, funny enough, it's one of the things that people ask me most of all is, I just can't get the undercuts on that single tooth. And the reason is because the gap between the adjacent teeth is quite small. You've got a big camera head, like so, going into a tiny little space, and how do I record those spaces? So I'm going to show you firstly on the mannequin, so you can really get a good clear vision of my hand position in relation to the patient. Now again, remember we talked about it last week, so my patient right now, it's probably about right. We're going to do a lower, an indication on a lower here. We'll also cut to the scan screen as well. Now I'm going to assume that you've already done the nuts and bolts. You've done the scaffold, you've done all your scanning protocol. We're going to really hone in not only on these undercut sections in this little section as well. Okay, let's jump into it. So our scanner head goes, or our scanner button is on. Now the first thing I do, now a cameraman will come in and out of the screens from time to time. I hope you don't mind with our cinematography, even the professionals do it from time to time. But we want to get really good footage of hand position. And I will ask our cameraman just to come around behind me a little bit further. Now the first thing that I do is for a lower scan, now I do go into the sulcus depending, but if I'm going to be working on this quadrant 3 missing premolar, I would typically put my index finger on the occlusal surface of the quadrant 4, opposite to that space. Now that gives me a lot of space to be able to get my thumb supporting the head. Now we talked about it last week, how important it is, because we're going to be doing some fancy and funky moves here all over the shop, and that pivot point becomes very, very valuable for you to access those undercuts. So my scan is still running, and don't be scared to leave it running. It's not the end of the world, and it is yeah, let's jump into it, right? Enough talking. So I'm just gonna look at the section that we're working on here now. So I'm just doing a rough scan, rolling to the lingual, and I'm just focusing on this edentulous space. Funny enough, this model has extractable teeth. So if we want to get a bit more edentulous arches, we can just pull these teeth out. Now I'm going to cut across now to our screen. And having a look at our screen now, you'll see that I've got some massive undercuts. And it's actually, this is very common. I mean, I've walked into so many surgeries where, like, I can't get to that undercut. It's very common, so don't beat yourself up about it, but we're going to show you a trick to be able to get it now. And it's mainly that back molar that poses a big problem for a lot of scans. So let's now have a look in the mouth again at how the hand position helps to attack those undercuts. Now this is a very basic partial, right? In this instance, look, I'd probably prefer an implant for this patient if the bone was sufficient, but let's say we're just doing a small little denture that spans potentially around, if it's a chrome, or a little valplast potentially, or whatever it might be. We do need to get those undercuts so that the lab knows exactly what they're working with. So here's my hand positions. Again, placing my index finger onto the occlusal surface of the quadrant 3. My thumb is supporting the scanner head. I'm coming back in. Now I'm over the top, and I'm just hovering over the top of the molar, and as I then pivot from my thumb, I lift my elbow up and I rotate it. And as I do that, you can see from the screen, as we cut back from my hand to my screen, and I'm rolling more and more, we're getting that undercut. So again, here's my move. We're coming in, index finger down, thumb being the pivot point, so that you can roll the scanner, because you're getting into you're going to tie yourself up sometimes, and you need that finger to support you. So again, touching, rolling, up, round, and under. And as you can see there, we've basically got the undercut. Now, if you've got more undercut on the buccal side, then you do the same thing again. Rolling, up, down, and under. Now you're going to see in a moment, because I'm going to bring a live patient in with a similar indication to this, that it's actually quite tricky, because you've got cheeks and all sorts of things lying around the place. Now we're going to just get the undercut on this, premolar as well. And again, rolling. Oh, so it can be quite tricky. You need to get that black square into the right position. Like so. So now we've got all the undercuts, and it's quite tricky. You saw that. I mean, I've got all the hand positions moving and happening, but we do get there eventually. Now, sometimes there are some undercuts that are so far buried under, and you find that on crowns or implants, potentially an abutment tooth is an implant, and it just goes so far under, it sinks so far under. The camera sometimes just can't get it. The good news is the appliance will probably be blocked out in that position anyway, but don't use that as an excuse. Go for the full undercut. Now I'm going to swap out my mannequin now for a real live patient who has the same indication as this. Well, it's going to be on the upper opposing. It's hard to find patients these days. So let's swap out our articulator now for a real live patient with that same, with our missing tooth. Mr. Patient, if you can jump in now, that'd be great. Yep. Put my mask on. Now I'm going to delete out this scan now, and do the same thing, but with a real mouth. Now the real mouth is a little bit different. So if our cameraman can come in again, because now we're working with not just the mannequin which just got teeth, right? Now the mannequin is one very good realistic way to do this, but now when you've got lips, cheeks, tongue in the way, it does get a little more trickier. Again, for this scan, I'm going to pretend that we've already done the nuts and bolts, and I'm going to focus in just on that one little edentulous space and the undercuts that are surrounding it. Okay, so let's get to work on this one. So opening up. Now, how's my posture? Not too bad. For the upper, like I said, it can be upper fraction. My computer's quite good. I can see what I'm doing. Maybe turn it a little bit more. And opening up for me. Now, you'll notice my index finger. And again, look for my index finger when I'm scanning, because that's my support finger. My support finger, again, is actually on the lower occlusal surfaces of quadrant 4 to support my thumb, even though I'm working up in the, so we're actually going to be working with a back molar, so it's a 6. So we're going to be working with a 2-6 today. The spaces are 2-6. And I'm using my thumb now. So let's have a look here. So scanning back, I'm looking at my screen. I'm just getting the nuts and bolts of this section. Just getting the nuts and bolts so we can then fill in the gaps later. We're good patients, don't we? Prepared to come in and do this. Just going to get a little bit more information there. That's good. I don't want to get too much. I want to have undercuts. Now, one lesson we did talk about last week. Now notice how I'm still got my scanner on. And if you are doing denture scanning, this is just a little tip I've just thought of. Sometimes you're up at like 3,500 images. Don't be scared, as long as your laptop is as good and powerful as potentially this one here, or you're following the recommendations of 3Shape for your computer. You can leave this thing running. But if you're at 3,500, sometimes I don't stop because it takes a long time to load to go again. So I just leave it running and then I can go back in again. But remember last week we talked about how I'm going to access the back or the distal aspects of a 7 or an 8, for example. And this is how you do it. Remember, you get the patient to close about halfway, and then you'll find that your scanner will slip in around as the intracoronal arch opens for you. Let's have a try. So now he's massively open. I can't get there. Now, if you can just close about halfway, I can then skirt around the bottom, around the back. We're going to go this way for that other little corner there. And we access that complete distal surface of the tooth. Now, the most important thing is now we're going to look at the undercuts. So having a look now at my screen, you can see the undercut's quite significant. And again, when it's as big as what I've got here, it won't go green because it's just too big. It's like, gee, what have you done? It's a cavern here. And so we know we've got a lot of work to do. So again, I'm supporting my finger, supporting my scanner head, pushing my button before I get in there, and I'm going back to my position. Now I know where I'm working, and I've actually got to rotate my scanner this way as I then rotate it that way, parallel to the place we're going. See how we're catching it? Now I'm going back this way, I'm rotating my scanner this way, and I'm going up. Up. That's a persistent one. And then sometimes you've actually almost got to go perpendicular to the patient in order to get that undercut. Again, rolling around, it's really testing it, and that's, I guess, with live TV, you've got to take this into account, don't you? But as we almost got it there, and you can see your scan count is really driving and growing. I want to get that just to show you how we go there. Sometimes saliva plays a part in this as well. There we go, we're almost there, and we got it. There you go. So it's not always easy. And you notice that I had my hand position running across the patient. And this is how you know this is real life TV, right? If it was we're mucking around and it just gets it like that. Well, it's not always like that. And please don't beat yourself up about it because it's quite difficult. It's actually quite difficult to do. So there is our hand position. So again, looking at the patient, when you've got the difficult undercuts, again, we're supporting our scanner, index finger down, thumb up, we're rolling. Sometimes you'll need to move, and my thumb is still supporting the scanner, and I roll to get into those undercuts. Very important to think about that. And again, the other side, again, index finger down, rolling perpendicular to the patient, getting that camera, getting that the square inside inside the frame, inside the picture. Well, that's your one toother. Now take those principles with you. Thank you, Mr. Patient, you can jump out now. Take those principles with you as you see your patients, and again, it's just that finger support, and again, all those pre-fundamentals that Joe and I spoke about last week. will really, really assist you in getting those undercuts. Okay, now we've looked at a single partial tooth. Let's now look at a fully upper edentulous arch. We'll get our second patient to jump in the chair for us if we can. Okay, back with patient 2 now. Patient 2 presents with a full upper edentulous arch. Now, I've been very privileged to be able to get this patient in here because she's one of my households, so I can almost demask and communicate a bit better with you. We're going to do two things. We're going to firstly just do a full upper edentulous arch scan. We're going to have a look at that, and I'll give you some tips and tricks, some finger positions to help you do that as well. Hopefully I do some things that aren't a bit weird and wonky. Sometimes you'll get overstitching in the palate. So if I do that, it'll be a good lesson for you, and we can go back and work on together how we can avoid that as well. But it's quite a good exercise to do together. I will start by running around where the occlusal surface would have been, and then I'll start to fill in the gaps. And the last thing I'll come back to, I do actually like to go down into the hamular notches in the first pass, particularly in quadrant 2. You'll see from our screen as well, so we'll cut screen, cut to hand, cut to screen, cut to hand, and we have a fantastic, we'll get out Mr. Cameraman to pull in for us as well. So first things first, I've set up the scanner to do the full upper. I'm going to get my patient up a little bit higher, so she's a little bit shorter than our last patient, so we want to get that perfect height, right? We want to get that scanner in the right position, a patient in the correct position. Now for the full upper again, sometimes you need to have a look get your head under there and have a look, and again why I like to do the frontward scanning for full upper scans. So let's get into it now. On your Trios you do have several options for your scan strategies and protocol. I've selected just the edentulous arch scan, but what I'll show you directly after this is I've already done a PVS impression inside her current denture, and I'll teach you the reference denture scanning technique as well, and that is another little click button of itself. And those are really good assets for you to let the lab know what you want, what you're doing, and what you've got. It allows them to flip models and whatnot. So let's start with our scan. Opening up for me. Now open up, we're going to do the top here. So I'm going to start right down the back, hamular notch in quadrant 1. And if you notice my fingers again, in this instance, my index finger is actually up inside the sulcus. Now if you're watching the screen, watching me, you can see the hand position. Now I like to come back down and do a little bit of the sulcus as I make my way back. Let's just stop there for a moment. So there's my first pass. I'm going to zoom out a bit and you can see on the screen. Here's my first pass there. So all I've done is I've just taken, like if it was a dentate person, I've done the same thing. I've just run around. Now what I'm going to do now is I'm going to start to fill in the spaces of the palate. The palate is the place where you can overstitch because you've come from left to right and then you're starting to fill things in. It is possible to get an overstitching there. So you be careful with that and make sure you're very, very strict on your scan quality control. I'll show you how I'm going to fill in those gaps. So again, I've got my index finger in patient's sulcus, so that allows a support point for my thumb. So I'm going back in, supporting. Now what I'm doing now is I'm starting to fill in the gaps. And I'm linking the left side to the right side. I'm kind of hoping I'll do an overstitch so I can show you it. It's amazing when you don't want them, you get them, but when you want them, sometimes you can't actually make a mistake. It's a bit weird. Now there's often questions about extensions of a denture. Now that's quite back. I mean, I can see the vibrating line there, so I know I've got a massive amount of extension. But when I look at it, I haven't got a lot of extension into the hamular notch area, which we need that for denture records, right? So let's try and achieve that. So again, I'm up and I'm rolling into the hamular notch, and you can see that on the square. So look at that. I mean, I've got full sulcus record there, full sulcus record. And now what I'm doing is I'm actually using my index finger to retract as my thumb pushes into the sulcus. So I've done the quadrant 1 sulcus now, and you can again see that on the screen, the video screen of the Trios. And so I've done basically one half. I mean, it's pretty straightforward, right? This is a very good patient. Now the upper is a lot easier than the lower. Now don't beat yourself up if you've got a very flat pancake upper with minimal bone, minimal rolling aspects, which is much easier to scan. You can't get them all. It might be, 19 out of 20 you'll be able to do. There's that 1 out of 20 that you just won't be able to do, especially in the lowers when it's as flat as anything and there's saliva everywhere, tongue's going crazy. So don't beat yourself up. There is a place sometimes for the conventional, but you know what? This is amazing. And, at 19 out of 20 is not bad in my books anyway. So let's go and finish off the scan on the other side as well. So again, I showed you last week the rock and roll movement for recording incisal ledges. I use the same technique to record sulcus. So again, now as I go to record quadrant 2 sulcus, I'm actually now resting on the lower quadrant 4 premolar as I come along. So I'm coming along, and then I'm going to retract with my index finger, get into the hamular notch. So now I've got beautiful record there. Moving my way up, and I'm moving and I'm rolling. I'm rolling and I'm moving. If you come to the anterior section and you just can't get it, you will need to do a bit of a hand tweak. Now this is where I grab the lip, if the cameraman can come in here, and have a quick look at what I've done with the lip here. So I'm pulling it out, and while the frena is very difficult because it's a very mobile tissue, and sometimes you won't be able to record that. But what I do is I actually get the patient to relax, close about halfway if you can, and I get my scanner, and I actually just go right over the top of the frena, just like this. And hopefully you're seeing both views here, and that's your scan. Pretty straightforward, but the result is fantastic. We'll talk about mucocompressive and static a little bit later in our debrief, probably Joe and I. Joe, we can talk about that. But that's our nuts and bolts scan. I want to show you now the reference denture technique. The reference denture technique will mean, now I've got our poor patient's denture here, and I've done a PVS before we went on air this evening. And if we come over here, if our cameraman can come over here a little bit closer, you'll see here that our PVS, so you need to be able to do a PVS. I've actually got a little bit of a bubble there, which is not such a big deal. And again, be pedantic about your impression. It is important. But what I've done is I've got a really nice compressive sulcus aspect. And I'm going to show you now how you can sort of marry the old school and the new school. The reason I like this technique so much is because the patient comes in for appointment number 1, presents with dentures that have a decent occlusal record, so they're marrying up okay with their lower. So what you can do is you can do your PVS and you can do what I'm about to show you. You can then record the bite at the same appointment. You can then get your texture and mark some points on the anteriors, and there you'll be able to go straight from your first appointment to your try-in straight away. And that's the benefit of the reference technique. So you will reduce your appointments. Whereas with the Edentulous, like we just had just now, you will find that you will still need to have that MMR appointment. But irrespective, it's a very good impression technique. Let's have a look now how we do this. I'm just going to delete my upper scan. Okay, and I'm going to select the reference denture icon on Trios. Now, I believe that the scanner is optimized for the indication that you're doing. So it is a good practice to actually follow the manufacturer's recommended protocol. So I've selected that now on our screen, and I'm going to start to scan. Now, there are some tips. Now, again, we talked about you can't get them all. I'll tell you what you can't get sometimes with these. If you've got a very good lab, you can get around it though. Sometimes when the depth of the denture is extremely deep, I'm talking sort of, 25 to 30 millimeters, or the flanges are wrapping back around, you will find that you will find it very difficult to get your scanner to take a picture of everything. You'll be able to get most, and if you can just get most of it, your lab, if they've got some good CAD experience, will actually be able to help you there and fill in those little gaps. But this is a great case for it, and I'm thankful that I have an easy case, and I'll show you some of the things that can go right or wrong. So the first thing I start on the back here. Mr. Cameraman, you want to come in here? So I'll come and I'll scan over here so you can get a good view of it. So I'm just making my way down the depth. starting to fill in a few gaps as I go. Again, it's very easy to overstitch when you're doing this. So just getting our nuts and bolts again. Nuts and bolts, and I'm coming back around for a second pass. Sorry, cameraman, you'll have to follow me on this one. Tricky to do it, two things and all at once. But I'm trying to get the inner workings of the palate first. I'm going back to get my holes that I've missed. Just a rough here again, and we'll fill in our palate here. Now the palate is where, again, you can get overstitching. So we've got basically a rough scan done now of our fitting surface of a denture. This is the most common mistake. Now, firstly, I'll premise with this. We need to record the fitting surface, we need to roll over the sulcus, and we need to record the buccal of the denture teeth. And why is that? We need the buccal because we're going to put that back in the mouth. We're not going to do it today. We're going to do it next week when we talk about occlusions, or 2 weeks from now when we talk about occlusions, because it's all about occlusions, and you're going to love that. So what you want to do is you actually don't want to, you want to be very careful how you get to the buccal. It's happened to me so many times. When you roll, you want to go around first and capture all the sulcus, and you roll just like that rock and roll move I taught you for incisal edges. You want to treat the sulcus of this denture as an incisal edge as you slowly roll over. Now as you do that, you will be able to roll to the, I hope you can see this well, you'll be able to roll to the buccal. So again, rolling, 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 and these are the things that you may not have thought of, but it's very important. But once you've come over the hill, once you've rolled over the sulcus and you're now onto the buccal, then you can be a bit more liberal. But again, you want to do this systematically. So see now I'm rolling, same technique, right? Same technique. And I don't care if I haven't got the whole tooth, I'm just trying to join the sulcus to the buccal of the teeth. And that is the hardest thing to do. Joining the sulcus, the fitting surface, all into the one scan, and doing it accurately without overstitching, which is, again, it's quite tricky. Now, okay, so I've now stuck it all together. I've pretty much got most of the tooth records. Some labs may want to cut, if you want to say, for example, reference the current teeth, you may want to roll to the occlusal as well. It makes it a bit easier, a bit more visible for them to see if they want to remove teeth and put teeth back into those same places. So if you wanted to do that, again, it's just simple, just rolling over. It's not a big deal. But I'm just finishing now off the tooth. And look, it's yelling at me. Scan's getting big, that's okay. Just don't stop. I think I said that in one of the articles we wrote recently. One of the tips that I've learned as you get to 2,500 scans, don't stop till you get enough. So don't stop until you've got everything you want on that scan. Now, that is your reference denture technique. So you've actually achieved, so if you're a big proponent of compression, well, you've achieved compression, you've achieved digital. The bite is so accurate, so accurate. In fact, I'd like this patient, if you can just, I'll put the chair down a little bit, if you can just tape aside there, I'm going to show you a couple more things that will maybe make a little bit more sense to you before we get into occlusion next time. Thank you very much for that, by the way.
Perfect, and we're back. So that was amazing, and thank you so much for our patient. But that was a really amazing how-to, I guess. I think it's so important again to learn how to be able to scan these kind of things and to take your scanning to the next level by not just doing things like crown and bridge and fully edentulous, but really trying to kind of advance the level of skill to those tricky parts, to those tricky scans. A lot of clinicians do kind of shy away from scanning fully edentulous or partially edentulous patients. They'll happily do it as an impression, but it means that they're not utilizing the technology that they've invested in. So I think learning things like this and being able to kind of prolong, or I guess extend the journey, the digital journey that a lot of dentists or clinicians are having is such an important part.
Definitely, but this is what I wanted to show you.
Right, okay.
This is what I wanted to show you before. And we will go through this next week, 2 weeks from now. I did want to show you, so these are some of the impossible occlusion cases that we will talk about 2 weeks from now. And an impossible occlusion by definition, or my definition anyway, is a case that you cannot basically need a block of wax to be able to take a bite. But the scanner, with a single tooth on the lower, this is a real live case. We probably won't do it now actually, because there's a lot of questions.
Yeah, and we do have next week.
Yeah, that's correct. So I will give you the scan strategy for these kind of cases next session, 2 weeks. And then I'll show you the bite strategy for that as well. I've got 2 real live cases that I really want to show you. But anyway, let's do a bit of a debrief and questions, I guess.
Yeah, absolutely. So we're going to jump straight in to some questions that have come through. So the first one, actually, we've got 2 that are very similar. One is, how do you get compression on a full denture? And then the other one is very much so, that's really amazing scan, but mostly dentures, especially full upper, rely on compressive tissue impressions. How do you do that?
Yeah, good question.
This is a very popular question when it comes to scanning.
I always get it. I always get it. So
yes.
I don't have a pre-prepared answer, but I have answered this on numerous occasions. I did do a bit of a test and a study, and most of the things that I do, I like to try and challenge, I guess, what we've learned. But there's never been a period in Earth's history where we can actually take an impression or a record of a patient and not touch them.
Mm-hmm.
So a lot of the premise of compression is based on a lot of trial and error, but it didn't take into account the future, right? Where you could actually do something without touching anything. So I've done hundreds of cases with the technique that I've just showed you. And what I've interestingly found, and when I was in my former employ, I was able to do hundreds of cases twice. 1 the old way, and 2 without touching anything, i.e. scanning.
Mm-hmm.
And I did find that some cases were more receptive to compression than others, where, for example, flabby ridges, things like that. But you actually don't want to touch a flabby ridge. You actually want to keep it out of contact, out of compression anyway. But I did find that there was no great difference. Not saying there was no difference. There were cases where a compressive impression was better.
Mm-hmm.
But for the vast majority of the ones that I tested, it wasn't actually that big of a difference. I do have a video, and I plan to put on tonight, but we're doing sort of the whole live thing, so it's not as easy to do. But one great case I had was a full upper immediate, and I have the video of it. And you see this lady, and I got the video, and she's just going like this. This is several weeks after issue. So there has actually been some resorption as well, funny enough. And she just can't get it out of her head. It's pretty funny.
I guess a lot of the big what's it called, answer back to that compressive is the mucostatic impression, right? So when you put 2 pieces of glass together, you put some water between them, right? They're static together. So there's that suction there. So I think that's the big argument in opposition to, whether you can get compression or whether it's actually that important.
I've actually got this, Joe. So I took this out of the denture that I used a bit earlier. The best answer is if you absolutely want compression, well, hey, you get it. And so you can do that when you have a patient's denture. It's very easy to do that. You can selectively compress the places that you want. And as I mentioned not long ago, the beauty of a reference denture technique is you can do all those traditional things. You can still pull out your PVS gun. And there's some people that are very, very handy with the PVS gun, and they can do some crazy things. So you can actually use that technique in the new world as well. So you can do both. And I do both. My preference is someone to walk in with a denture. I would always prefer that any day of the week than someone walking with no denture. It's always easier to do this than it is to the other way. But yeah, I hope that helps. But it does work. And test it, guys. I mean, I'm not the be all and end all. I've done a lot of them, but certainly we are pioneering in industry here. Stuff that's never been done before. How much fun is this?
It's amazing. Next question. What are the fits compared to jobs taken with impressions?
Oh, we just answered that.
Yes, I guess we did.
They're relatively comparable.
Some
aren't, some are. It's not bad. Worst case scenario, you can do a wash inside your try-ins. If you're doing a printed try-in or a milled try-in, you can always take a wash inside that as well, and you can rectify anything that you think you may have deviated from. You can fix that as well.
Is the Trios better than a lab scanner? I'm assuming they mean for like digital dentures and things like that.
Look, so don't think of the lab scanner and a Trios. They're kind of in a different space. This is for practitioners. So I don't make dentures. I don't do any lab work. Praise the Lord for that. But so yeah, look, if you're a practicing practitioner who makes your own stuff, poor guys. Anyway, it's a different category. So this is purely a clinical tool. It does scan, the lab scanners do scan, I think it's at 6 microns, is it?
Maybe
Maybe 4, I think.
4 microns is for the E4,
yeah. E4, that's right.
Yeah,
E3 is
7
at
for the
6.
E3.
Okay,
Yeah.
there you go. So that is far superior to this. I think these are at 25 micron, which is, again, it sounds like a big quantum leap, but in the scheme of things, it's nothing.
I think it's 6.9.
Oh,
actually.
there you go. Geez, it is pretty crazy then. So basically, they're different. They're a different beast.
Yeah.
I'm in practice. I'm with patients. You can't pick up a lab scanner and scan the patient's mouth. So I want to get in the mouth with it. That's the real main.
I think that's this question's a little bit loaded towards, because you made the decision a long time ago, the business decision, that you were solely going to stick to the clinical side of what you do when you practice. So you were going to offset the lab side of it. So it really, I guess, would come down to what your business model is.
Definitely.
If you're seeing patients and making your own dentures, if you're comfortable. I mean, I think a lot of, if we're looking at the prosthetist side of things, I think a lot of prosthetists might be a little bit more conservative in regards to going digital. So the idea of getting a lab scanner might be a little bit easier, because they can still practice, doing the impressions and then scanning those in and then doing that side of it digitally. It really does take a good step to actually then digitize the clinical side of it, even though we know that, with the clinical side, especially with scanning, we can reduce the number of appointments drastically. One to 2 appointments you can reduce it by.
Especially with a reference denture technique. But that being said, you technically could still take impressions, pour a model, scan with a Trios as well. So what happens on the back end is a different kettle of fish. I mean, if you want to get digital and you're designing digital dentures and printing and milling them on the back end, so to speak, you can still do it with this as well. There's actually no problem with that. The workflow supports that.
Perfect. So I mean, I guess the answer is.
But it may be a commercial lab that's receiving cases, you know what I mean?
So I guess the answer is both are really good. You just need to see what's right for your business, your business and what your day-to-day is. Yeah. Good.
If you've got 3 patients a week, okay, fair enough. And you're running a laboratory that's seeing other people's work, fine. Lab scanner would probably make more sense.
Absolutely. What have you found to be what have you found to be the limitations of this type of scanning?
Okay. That probably is in reference to reference denture scanning, because there are, I mean, you might have seen this technique online a lot, and they never tend to show you the hard stuff.
Yeah, of course.
Everyone pulls out their mad cases and they've done 5 takes and off they go. You don't really get the real world sometimes in media that you're watching. Some of the limitations, and it's not that often. I've got a ruler here. So what happens? I don't know if you can sort of see that. We don't have our zoom in camera for this part of the session, but with the depth, so 2 things. The flanges, a denture with where you've taken a reference denture and the flanges are rolling back in on itself. The camera head will sometimes struggle to get right down in the depths of it. So that is probably the only thing but there's ways around that. And so the way that you get around that, and again, this is a little bit of a hack, is sometimes you physically can't. It's not that often, but sometimes, if you've got a depth of palate, say 15 millimeters or more, you probably won't be able to get a few little holes down inside the denture. So the way you get around that is you actually when you roll to the buccal, you come down and around to the palate, and you pray that your person who made that one has used a wax spacer that's even across. The lab then can actually do a bit of a mock-up for you, and then you can adjust that. So you do some PIP paste and you can adjust it as well. So that's definitely one of the limitations, but there's a way around it. So
okay.
I hope that answers that question.
I think that does. I feel like this question also kind of runs into that. What do you do with really deep palates? I would say, would you say that a deep palate would be a limitation, like if to try and get the scanner in there?
You kind of get the head of the scanner. I've had some shockers.
Yeah.
And I can pretty much get, I might have I'm talking, a 5-10 millimeter circle that I can't get. And so what a smart lab can do is they can actually follow the contouring. They've almost got their sort of own built-in AI.
Yep.
And they can guesstimate how that hole that you've missed, it looks like. And then they can even draw a line on it for you. And you can do a PIP at your try-in stage if you've got a printed or milled, or depending on how you do it. If it's just a wax try-in you've got, then you can do it at the finish stage. You can adjust that at that point. That's kind of the only really way around that. I'd love to have like a microscope that you could put in there and the trios would shoot through it. There is a zoom tool, but it still won't get that.
I mean, a lot of other intraoral scanners, you have to be a specific height away from, even when you're scanning full dente, the scanner, you need to be a specific amount away from the tooth for it to be able to actually pick up the picture. Whereas we know that with the trios, you can completely come in, you can touch the teeth, you can touch the surface of the teeth with the head of the trios, which does make it, I guess, in ratio, one of the smaller heads in regards to that in the market for intraoral scanners. So I guess it does do I mean, I've scanned some pretty tricky, especially even like a low prep between two teeth can sometimes be a little bit tricky if you can't get all the way down there, especially if you want to pick up a deep margin or something like that. There are, I think there are some very tricky ones to try and get. I guess it's just learning the right techniques to kind of pick it up. The zoom function is quite a good one as well. So
when you actually click the zoom, guys, just bear this in mind. Once you click zoom, your picture count just explodes real fast. So you'll start blowing files out pretty quick. So be very focused on what you got to do with your zoom and then turn it off again.
On palates, actually, this is a question that I jotted down. You mentioned palatal overstitching. Do you mind elaborating on that just a little bit?
Sure. This is another thing that you need to watch for when doing mainly full uppers. So a full upper scan, it's basically, it's the same concept as the incisal edge overstitching. Well, it's actually, no, sorry, it's a little bit different to that. Basically, you're starting, this is probably not a great example, but you're starting at one side, you're running around where the occlusal would be, and you're coming to the other side. So basically, you've scanned from one side all the way around to this side. Now, sometimes, every time, this is every scanner in the world, every time you take, it goes click, 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 click. There's a slight, that's where the pictures are stitching together. And it's a very, very, sometimes, and it can be drastic sometimes if your technique's not good. When you get from the left side to the right side, the margin of error can sometimes grow. And that's why there's a lot of talk about full arch implant scanning these days and, going to photogrammetry and whatnot. I've actually got a solution for you, and we'll talk about that next session 4. That's exactly what the reason for it. So what that can happen then is when you then start to fill in your palate on the patient's mouth, there could be a slightly different height in the left and right side. And so when you go to join them together, it goes like that. And that's the overstitching. So you need to zoom in, check your palates that you haven't done that. And if you do that, that's what I mean by overstitch. I probably didn't explain it very well. Sorry, guys. If that does happen, just get your cutting tool, your laser, and just go chop it all out. And then when you're scanning across, almost come across more, taking the whole palate from left to right, almost the entire scan. That's one way if you find that's consistently happening. That's what I mean by overstitching.
Perfect.
It will bugger everything up, so don't do it.
I think one last question. Why would scanning a missing tooth be harder than some edentulous scans?
Yeah, well, it can happen to the best of us. And good. Is
that like, I mean, does that kind of tie into what I was saying before about trying to get into like a small area? Like, especially, I would say one of the hardest is if you've got a single missing tooth in the lower anterior where you've got long teeth, it can be
really hard.
Yeah.
You got to get in it from the back and turn like this and come to the front like that. Single teeth, small spaces. This is a small, very small head comparative to many scanners out there. But basically the theory is if the camera can see it, it can capture it.
Yeah.
If you can't get the camera into a position to see it, it won't capture it. So then, everyone's scanning all these full arches and teeth missing all the time. Again, if you grab that scan and you started to twist it, that no one really shows you the under angles that they've missed, right? So we've been really honest with you tonight that sometimes it's very hard to get those. But for an indication such as a denture, we require a denture scan requires more information than anything else.
Yep.
We need the other side. We need we need to understand the undercuts of teeth completely. So you need all that information. So don't underestimate the complexity of a denture scan. It is at the top echelons of complexity. And so you guys jumping into this is really a compliment to your courageousness. But yeah, that is exactly why it is. But like I said, you've seen some of the moves that I did. It's really just getting that scanner perpendicular to the patient and then rolling like that. That'd be how I'd address it, but I hope that all helps.
Yeah, absolutely.
It's informative to you.
I think that's all we've got in the questions. So before we leave, please, there's a link in the comments to register for the next webinar in the series, which is impossible occlusions.
My favorite topic.
Yes, I know it is your favorite topic. Do you want to kind of just give us a little rundown about what you kind of be going through in that?
Sure. Yep. Impossible occlusion, we talked about this before, is anything that you would, so basically I want to help you get rid of appointment 1, appointment 2, and appointment 3 in appointment 1. And you can do that, especially with the partials, with one proprioceptive contact. So I've got 2 cases that we're going to do together. I will give you a bit of a scan strategy because we didn't do that tonight, but I will show you that as well, and it's important. But yeah, that. We're also going to talk about a research project that in my former life, where I took 300 cases for a 965. If you know what a 965, it's an occlusal splint.
Okay, right.
What I did is,
I didn't know that.
I worked in an 18-chair practice.
Yeah.
I said to all the dentists, just throw all your patients that need a 965 in my book. I'll do your scan for you. I'll record your bite for you. And then you can take the glory and the cash.
Got it.
I kind of love that. So we had 300 cases where I perfected a technique to open occlusions, and then we were starting to use them. We'll use it for splints, and I'll tell you why next session as well. We don't want to bore you now. And then the other cool factor that we're going to look at is you can use that open bite scan recording technique for full mouth oral rehab. So you can open it up, and then you can let your Crown and Bridge lab go crazy with mock-ups and whatnot, getting you ready.
Amazing. Well, that's that sounds like a really good, that sounds like it's going to be a really good session.
It's going to be good fun.
So please make sure that you do register in the comments. Also, session 4 is actually going to have going to be live. So we do invite anyone who's in New South Wales or in Sydney to actually come and join us in studio here with us, and we'll try and do a hands-on component as well with you. So please make sure you also register for that. You can find that on the Dental Access website. Just before we do go, I want to say a big thank you to our sponsor, Dental Access. If you're looking to, if you aren't digital yet and you're just looking to go digital, or you want to be able to expand your digital portfolio, please make sure you give them a buzz or get in contact with them so that you can buy a Trios, right? Perfect. So thank you very much, Leif.
Pleasure.
And
Thanks,
thank you for your wealth of knowledge. We really do appreciate it.
It was good fun.
Yes, it was really good fun. Thank you very much, everyone, for joining us, and stay safe. Cheers.